There's this really comforting illusion we tend to harbor about medicine.
Oh, absolutely.
Oh,
Especially when you're talking about emergency medicine.
Right. We want to believe it functions as this perfectly engineered deterministic system.
Yeah, a binary process.
Exactly. The prevailing thought is you input a symptom into this vast medical machine, the machine runs an algorithm, and then boom, out pops the perfectly calibrated treatment.
If A, then B. It's incredibly seductive to view the world that way.
Because it feels safe, right? I mean, a patient presents with a specific set of vital signs, you just apply the corresponding flowchart, and the problem is resolved.
We crave that certainty, especially when, human lives are actually hanging in the balance.
Yeah.
The idea that medical care is basically an algebraic equation, where solving for X just guarantees a cure, that's the foundation of how the general public views the field.
And honestly, even how a lot of novice practitioners view it at first.
Totally. But the moment you step outside the sterile, temperature-controlled environment of a hospital and into the pre-hospital arena,
Things get messy.
that pristine equation just completely shatters.
Which is exactly why we're doing this today. Welcome to our deep dive, everyone. Today we are taking a fascinating look into the high-stakes, deeply chaotic reality of emergency medicine.
It's a wildly complex world out there.
It really is. And our mission for this deep dive is to uncover the cognitive frameworks, the secrets, really, of elite clinical decision-making.
Unpacking how the best of the best actually think.
Right. And I want to note that this deep dive is specifically tailored for you if you're a student stepping into the medical field.
Whether you're an EMT, a paramedic student, or just anyone building clinical judgment.
Exactly. But honestly, even if you aren't in the medical field, the cognitive tools used to manage this kind of life and death chaos, they are incredibly useful for anyone facing high-pressure situations.
Absolutely. The mental models apply everywhere.
So to do this, we're pulling from a really authoritative source today.
Yeah, we're looking at a fantastic chapter on critical thinking from a core paramedic training text.
And this text attacks that illusion of certainty we were just talking about right from the very beginning.
It does. It introduces this vital warning against the myth of what it calls cookbook medicine.
Cookbook medicine. I love that phrase.
It's so descriptive.
Yeah.
The text argues that treating paramedicine like a culinary exercise, where you just open a book, find the complaint, and follow the prescribed steps, is a fundamental failure.
Why is blindly following steps like a recipe such a recipe for disaster in paramedicine, though?
Well, it comes down to the reality of the pre-hospital environment. It's incredibly dynamic.
Mm-hmm.
You're walking into scenes that are structurally unstable, geographically bizarre, or in a lot of cases, overtly unsafe.
You're dealing with bad weather, limited lighting, panicked bystanders.
And patients who almost never present with textbook symptoms.
Right.
I mean, a myocardial infarction in a 30-year-old female might manifest as generalized weakness and jaw pain.
Which looks completely different from the classic, crushing chest pain in the 70-year-old male.
Exactly. So if you're a cookbook reader, just scanning the index for a generic description to trigger your step-by-step response,
you're going to miss what's actually happening.
You'll entirely miss the nuanced pathology unfolding right in front of you.
It makes you think of, okay, in most other disciplines, a cookbook is exactly what you want, right? Standardized procedures reduce errors.
Sure, in a controlled environment.
Exactly. A cookbook assumes you're operating in a calm kitchen. It assumes your ingredients are pre-measured, your oven temperature is perfectly calibrated.
The lighting is perfect.
Right. But being a paramedic, it's like being a chef in a kitchen that is actively on fire.
That's a great analogy.
Half the ingredients are missing, the power is out, and you have to invent the dish on the fly while someone screams at you.
Which means you can't just look at a recipe card. You need deep, flexible knowledge.
So how does a student transform from one of these cookbook readers into a master clinician?
Well, the text lays out a really clear roadmap for this. They call it the 4 cornerstones of effective paramedic practice.
Okay, let's start with the foundation, the first cornerstone.
The first one focuses on gathering, evaluating, and synthesizing information.
Which sounds straightforward, but as we just established, gathering data in this environment is incredibly messy.
Oh, it's a minefield. Gathering information isn't just taking a nice, orderly history.
Right.
The cognitive load is immense. You have to extract data from people of vastly different ages, educational backgrounds, and communication abilities.
You're dealing with severe language barriers, hearing impairments,
Neurocognitive deficits, dementia, and quite frequently you're interviewing people who are under the influence of drugs or alcohol.
whose perception of reality is already heavily distorted. But wait, let me push back on this for a second.
Sure.
Isn't gathering information just writing down what the patient or the bystanders say?
See, that is the exact trap novices fall into. The stenographer trap.
The stenographer trap. I like that.
They write down what the bystander says
Yeah.
and just accept it as objective truth. But the text explicitly demands that the student aggressively evaluate the validity of that info.
So you have to be more like a medical detective?
Precisely. You have to use objective judgment. You cannot take a single source's word for it. You have to triangulate the data.
Between the scene, the patient, and the bystanders.
Right. Does the physical scene actually match the narrative? Does the mechanism of injury align with how the patient presents?
So if a bystander claims the patient just tripped and fell,
But you look over and observe a deformation of the steering wheel and a massive spiderweb crack on the windshield.
right, your objective judgment has to override the verbal narrative.
You have to discard that invalid data before you can even begin to figure out what's true.
Okay, so once you've navigated that minefield and isolated the actual clinical facts, you move into the synthesis phase.
Which is where the real magic happens.
And the text provides this highly specific case study to make this concrete, which I'd love to walk through.
Let's do it.
Okay, so you're called for a 64-year-old man who is reporting chest pain.
Classic EMS call.
Right. During your history taking, you uncover 3 key pieces of his medical background. 1, he's had type 1 diabetes since childhood.
Okay.
2, he started smoking in high school. And 3, he was diagnosed with COPD, chronic obstructive pulmonary disease, in his 50s.
Right. Now, a Cookbook paramedic hears the chief complaint of chest pain, flips to the chest pain protocol, administers aspirin and nitroglycerin, and considers the job done.
But a practitioner operating within this first cornerstone has to actively synthesize those comorbidities, right?
Yes. The text refers to this as mentally gluing the diseases together.
Mentally gluing them together. Let's look under the hood of that physiological glue because it's fascinating. Why does it change the paradigm of care that this chest pain patient has long-standing diabetes and COPD?
Well, because we aren't just dealing with a localized heart issue anymore. We're dealing with a systemic cascading failure.
Okay, break that down for us. Start with the diabetes.
Sure. So we often shorthand diabetes as just a blood sugar issue.
Yeah, that's what most people think.
But fundamentally, chronic hyperglycemia is a vascular disease. Over decades, elevated glucose levels cause profound damage to the vascular system.
It degrades the circulation.
Exactly. It degrades the inner lining of the arteries. This leads to accelerated atherosclerosis.
So the blood vessels become stiff and narrow.
Very narrow and highly susceptible to plaque rupture. So before we even address the current chest pain, we know this patient's circulatory plumbing is basically corroded.
Right, the pipes are clogged.
Mm-hmm.
And then you add the COPD on top of that.
And COPD introduces a catastrophic failure of gas exchange.
Because of the smoking.
Right. Chronic smoking destroys the alveoli in the lungs, radically reducing the surface area available for oxygen to even enter the bloodstream.
So you get poor gas exchange,
Yeah.
hypoxia and hypercarbia.
Exactly. A persistent state of low oxygen and an inability to clear carbon dioxide.
So, synthesizing this. The diabetic vascular damage means the vessels can't effectively deliver blood, and the COPD means the blood that is being delivered is incredibly oxygen poor.
Right. So the aha synthesis moment for the student is realizing that this chest pain isn't an isolated symptom.
It's not just a generic heart attack.
No. You have to realize, I have a patient with diseases of both circulation and gas exchange. Part of the heart might be actively dying because the corroded vessels can't deliver what little oxygenated blood exists.
Wow.
Assuming this is acute coronary syndrome, the student must treat the combined effect to prevent the unperfused section of the heart from dying.
You can't just give a vasodilator to open the pipes if you don't also address the profound hypoxia.
Exactly. You are intervening in a multi-system collapse.
That requires so much physiological bandwidth to conceptualize in real time.
It's exhausting, but it's what saves lives.
Okay, so you've gathered the info, you've synthesized these cascading comorbidities, now you have to act.
Which brings us to cornerstones 2 and 3.
Developing a treatment plan and independent decision-making.
Right. And here is where we find this massive tension for students.
Yeah.
How do you balance following the rules with thinking outside the box?
Let's start with cornerstone 2, developing a treatment plan. You have to differentiate between your lists of problems.
Yes. The text introduces 2 concepts here. The differential diagnosis versus the working diagnosis.
Okay, what's the difference?
The differential diagnosis is your cognitive brainstorming list. It's the wide net you cast based on the initial presentation.
So for the 64-year-old with chest pain, the differential includes a myocardial infarction, a pulmonary embolism, maybe an aortic dissection.
Every life-threatening possibility. But you can't treat all of those simultaneously because the treatments conflict.
Right, giving blood thinners for a clot will kill a patient with a torn aorta,
Exactly. So you have to narrow that list down to your working diagnosis.
which is the one hypothesis you base your immediate treatment on.
Correct. And once you formulate that working diagnosis, your actions are heavily guided by your systems protocols or standing orders.
Right, let's talk about protocols, because they are essential. These are the legally and medically defined standards of care, right?
Yes, they dictate exactly what therapies you can do autonomously.
And when you have to actually call medical control, like calling a physician on the radio to ask for permission to do something,
They're the guardrails. They exist to promote a standard of quality. Regardless of which ambulance crew responds, the protocol ensures an evidence-based standard is applied.
but the text points out a fatal flaw with protocols, doesn't it?
It does. Protocols are inherently linear, but human pathology is profoundly multidimensional.
They fail to address vague complaints.
Exactly. If a patient says, "I just feel an impending sense of doom," or "I've been weak for 3 days," there is no algorithm for generalized malaise.
And they struggle with multiple disease etiologies, like our diabetic and COPD patient,
Right. The respiratory protocol might be in direct conflict with the cardiac protocol.
which creates this huge tension for a student. I mean, you are drilled on protocols, you're told they are the law, but then you're told they aren't enough to save your sickest patients.
It's incredibly stressful.
Yes.
But that tension is where Cornerstone 3 comes in: independent decision-making and clinical judgment.
This is what saves the day when the algorithm falls short.
Exactly. Atypical presentations require multiple treatment modalities. So the text asserts that the circumstances, not just the algorithms, have to dictate the plan.
You have to possess the knowledge to know when a protocol is actively harming a complex patient.
And the courage to deviate from it safely. Necessary changes only happen if the student flexes their critical thinking skills.
Okay, so this all sounds amazing and very logical in a calm classroom setting.
Right, sitting in a comfortable chair.
But what happens when the adrenaline actually hits? Which brings us to the final cornerstone. Cornerstone 4. Thinking and working under pressure.
Because applying high-level pathophysiology is one thing when you're relaxed.
Doing it during a massive sympathetic nervous system dump is an entirely different biological challenge.
It really is.
Yeah.
And the text gives this visceral scenario to set the scene.
Yeah, let's walk through the cyanotic child scenario from the text.
Okay, so imagine you're dispatched to a residence. You ring the doorbell, and the door is flung open by a hysterical mother.
Oh, man.
And she immediately thrusts a 14-month-old infant into your arms.
And the text says the child is apneic, not breathing, and deeply cyanotic, meaning they're turning blue.
Because they've just been submerged in a bathtub.
In a fraction of a second, you go from drinking coffee in the ambulance cab to holding a dying infant while a parent screams in your face. How does a student mentally survive that moment without just completely freezing?
It is the ultimate test. The amygdala registers a profound threat, right? You get this massive adrenaline and cortisol dump.
Your heart rate spikes.
You experience auditory exclusion, tunnel vision. Your prefrontal cortex struggles to remain online.
The thinking part of your brain just shuts down.
Exactly. So the text emphasizes that only a combination of deep knowledge and excellent ingrained clinical skills averts disaster here.
You have to analyze the situation and perform incredibly quickly.
And to manage that pressure, the very first step is quantifying the crisis. You have to make a rapid, binary triage decision.
Determining if the patient is sick or not sick,
Yes.
which sounds like such a basic concept for an advanced field, sick or not sick.
It sounds rudimentary, but it's an essential heuristic. Not sick doesn't mean there's no problem. It just means the patient's compensatory mechanisms are currently holding things together.
They're maintaining homeostasis.
Right. Sick signifies that compensation is actively failing or has already failed. They are dynamically unstable.
For the sick, you have to quantify how sick they are to prioritize care, like, do we treat on scene or do we treat en route to the hospital?
And doing this is exceptionally complicated with multiple patients or with infants.
Because pediatric cases are so tricky, right? Infants have this incredible physiological reserve.
Oh, massive reserve. They will compensate by drastically increasing their heart rate and respiratory rate to maintain core perfusion.
So they might actually look relatively stable for a while.
They'll look okay right up until the moment their reserve is depleted, and then they precipitously crash into cardiac arrest.
They just fall off a cliff.
Exactly. And because infant cases are infrequent but incredibly serious, it induces profound cognitive pressure on the paramedic.
To help students build their judgment and survive that pressure, the text details a specific under-pressure checklist. Let's go through it.
It's vital cognitive scaffolding.
Step 1. Scan the scene.
Before you commit to the infant, you must perform a macro-level assessment. Are there environmental hazards? Is the bathroom floor slick?
You don't want to become a secondary victim.
Exactly. Step 2. Stop and think.
Which has to be the hardest thing to do when every instinct screams at you to act.
It requires immense discipline. But taking a controlled breath mitigates that adrenaline spike and allows you to consciously transition from panic to analytical processing.
Okay, step 3. Move forward, decide, and act.
Indecision is lethal. You must commit to a path.
Step 4. Stay calm and maintain situational awareness.
You have to deliberately fight the biological urge to tunnel vision. As you manage the infant's airway, you have to stay aware of the mother's panic, the arrival of fire personnel, everything.
Keep a wide cognitive aperture. And finally, step 5. Continually reevaluate.
You don't just initiate ventilation and assume it's working. Are the chest rises adequate? Is the blueness resolving?
And the expert text stresses that executing this checklist under pressure relies on 2 things: mental conditioning and muscle memory.
Muscle memory is absolutely key. If the physical task of securing an airway requires conscious thought, your brain is monopolized.
But if you've drilled those physical tasks thousands of times,
They become automatic subroutines. That frees up your higher-level cognition, your brain, to focus entirely on analyzing the patient and making decisions.
you condition the body to liberate the mind. I love that.
It's the only way to operate under that level of stress.
All right, so we've established the 4 cornerstones of what you need to do. Gather data, form a plan, use judgment, and execute under pressure.
The structural foundation.
Now let's look under the hood at how the brain actually processes this in real time. We are mapping what the text calls the 5 stages of critical thinking.
This is the internal engine of decision-making.
Let's start with stage 1 and stage 2, concept formation and data interpretation.
These stages begin the second you step out of the ambulance. Concept formation is the initial gathering of raw data.
So you arrive on scene, you're evaluating safety, the mechanism of injury, MOI, or the nature of illness, NOI.
And you're executing your primary survey, the ABCDEs.
Airway, breathing, circulation, disability, and exposure.
Right. You're rapidly identifying immediate life threats. Concurrently, you're gathering the sample history and baseline vital signs.
So that's the raw data. Then comes stage 2, data interpretation.
Yes, interpreting a heart rate of a 130 is meaningless without a deep foundation in anatomy, physiology, and pathophysiology.
You have to contextualize it. Is the high heart rate a response to internal bleeding? Is it an intrinsic cardiac arrhythmia? Or are they just scared?
Exactly. And here, the text gives some great advice for students. It notes that prior EMT experience is an excellent platform for this.
Because an experienced EMT already has a library of pattern recognition.
Right. They already have an internal gauge for what sick looks like. They aren't trying to learn the environment and the advanced medicine at the same time.
The text also makes a really fascinating point in this section about the practitioner's attitude. It says maintaining a compassionate attitude is paramount to providing the best care.
I'm glad you brought that up. We don't usually associate empathy with clinical logic, but it's intrinsically linked.
How so?
Because cynicism is the death of clinical curiosity. In EMS, burnout frequently manifests as cynicism. Practitioners start categorizing patients into buckets, like frequent flyers or routine drunks.
And once you categorize someone, you stop asking why.
Exactly. You skip the data gathering and synthesis phases entirely. Compassion forces you to remain engaged.
It forces you to look past the superficial presentation of an intoxicated patient and recognize, wait, maybe they have subtle signs of a slow brain bleed.
Empathy is actually the engine that drives thorough data interpretation.
That is profound. Empathy as an analytical tool. Okay, so moving into stage 3 and stage 4. Application of principle and reflection in action.
Stage 3 is the moment of commitment. You turn your field impression into a working diagnosis and apply the protocol.
You initiate the treatment.
But the critical part is stage 4, Reflection in action.
I think of this like steering a ship or maybe flying an airplane.
Flying is a great analogy.
Like flying into heavy clouds. You don't just set the wheel and walk away, right? You periodically check your instruments to see if your interventions are working.
Precisely. If you give a medication for an asthma attack, you don't just wait for the patient to say they feel better. You listen to their lungs again.
Are the airways opening? Or is the chest becoming silent?
If the intervention isn't working, you have to revise your impression. And the expert warning here is the danger of tunnel vision.
We mentioned that earlier. It's when you focus on only one aspect of a situation.
Under stress, the brain seeks relief by narrowing its focus to a single, obvious problem.
Like a horrific broken leg from a car crash.
Yes. You might pour all your cognitive bandwidth into splinting that leg and completely fail to realize the patient has a collapsed lung and is suffocating.
The leg injury becomes a lethal distraction.
Reflection in action means actively fighting that tunneling instinct. You have to keep an open mind because patients present with atypical signs.
Zooming out constantly. Okay, stage 5. Reflection on action.
Notice the preposition change. Reflection on action happens after the call is completely over.
The learning doesn't stop when you drop the patient off at the hospital.
Not at all. Reviews, critiques, and debriefs are absolutely vital. This is how clinical judgment evolves.
And the text emphasizes a crucial student mindset for this stage. You must be willing to accept that something went wrong.
Humility is everything. If your ego prevents you from admitting you made a cognitive error, you will permanently stunt your clinical growth.
You have to accept medical ambiguity and accept that better choices could have been made.
It's the only way to improve your ability to articulate your reasoning and fix flaws before the next patient.
Okay, so we have the philosophical cornerstones, we have the cognitive brain stages.
We've covered a lot of theory.
We have. So how do we translate all of this into a tactical, boots-on-the-ground framework for emergencies?
The text provides the ultimate cheat sheet for students. The 6 R's of clinical decision-making.
Let's run through these. Number 1, read the scene.
This is assessing safety, the environment, access, and egress.
Basically, how do we get a critical patient down 3 flights of stairs?
Exactly. It's also assessing the MOI or NOI and spotting eyewitnesses quickly to get the history.
Number 2, read the patient.
The comprehensive physical assessment.
I have to bring up a brilliant, deeply practical detail from the text here. I call it the handshake hack.
Oh, I love the handshake hack.
It's so good. As you approach a conscious patient, offer your hand to shake. If the patient takes it, grasps it normally, and answers your introduction appropriately, you have instantly gathered a massive amount of data.
In 3 seconds, you've confirmed they have a perfect Glasgow Coma Scale score of 15.
You've evaluated their visual tracking, motor control, skin temperature for perfusion, and airway patency.
Without deploying a single piece of equipment, it's so efficient.
After that, you run through the rest of the physical read.
Observe their level of consciousness, skin color, work of breathing. Talk to them about their chief complaint. Touch them to assess pulse rate and strength. Auscultate breath sounds.
Fix any immediate life threats. And grab baseline vitals. Which brings up a really deep detail from the text about vital signs.
Yes. A single set of vitals is clinically inadequate. It's just a snapshot in time.
It gives you no context. Is a low blood pressure normal for them, or are they actively bleeding out?
Right, so you have to take 2 sets of serial vitals for serious conditions to get comparative data.
And 3 or more sets for critical conditions to assess stabilizing trends.
Because serial vitals give you a trajectory, a movie, instead of a snapshot.
Okay, RS3 and 4. React and reevaluate.
Reacting is treating life threats first, building the differential diagnosis, and executing a plan.
And the text gives a great safety net here. If you can't narrow it down to a specific working diagnosis, just treat the presenting signs.
If you don't know why they are hypoxic, your reaction must still be to give them oxygen.
Makes sense. Then comes reevaluate. And you have a warning about this, right?
Yes. The text warns against falling into treatment mode during reevaluation.
What's treatment mode?
It's a neurological retreat. When the stress gets too high, practitioners sometimes subconsciously retreat to doing familiar physical tasks. They focus entirely on starting IVs or bandaging and abandon the analytical process.
They work on the patient instead of for the patient.
Exactly. You must step back, add secondary assessment info to the primary survey, and ensure your interventions are actually working.
Which flows right into our number 5, revise.
If the reevaluation shows the patient is deteriorating, you must have the open mind and cognitive flexibility to revise the plan.
Pivot to a new strategy as new data appears.
Yes.
And finally, our number 6, Review.
The continuous quality improvement loop.
Whether it's a formal CQI meeting with a medical director, a formal field code debrief, or just an informal chat with your partner while cleaning the rig.
This is how you prevent repeating mistakes. It brings it all back full circle.
It really does. So let's synthesize this journey we've been on.
We covered a lot of ground today.
We moved away from the myth of cookbook medicine. We explored how to master the 4 cornerstones: synthesis, planning, judgment, and under-pressure execution.
And we broke down the cognitive stages and utilized the 6 R's to turn chaos into a structured clinical response.
It is a massive cognitive architecture to build, but to leave you, the listener, with a final provocative thought to mull over, I want to toss it back to our expert.
The text really builds up to this idea. While studying anatomy, pathophysiology, and protocols gives you the vocabulary of medicine, that's just the baseline.
The raw words.
Exactly. It is the reflection on your mistakes, the rigorous debriefs with your partners, and the constant fight against cognitive biases that actually teach you to speak the language of clinical judgment.
The vocabulary versus the language.
So next time you face a high-pressure situation, medical or otherwise, ask yourself, are you just reacting based on a cookbook? Or are you actively reading, reevaluating, and revising in real time?
And you speaking the language. I love that. Thank you so much for guiding us through this incredibly complex landscape today.
It was my pleasure.
And thank you all for joining us on this deep dive. Keep learning, keep questioning the algorithms, and we will catch you next time.